Good morning, everybody. Good. And thank you, Paul.
Thank you.
Appreciate the opportunity to talk with you today. I was appointed by Deputy Secretary by Governor Schwarzenegger about a year and a half ago, and it was under the pretext of really a new era in healthcare with the advent of the high-tech stimulus program under ARA. And since then, we've had health reform and various other initiatives. It's an extremely exciting time for all of us. What I want to relay today is some of the challenges that we see in the environment, some of the opportunities that we see both with health reform and high tech and others, and where I think we can go and what are the chances for CITRIS and new and innovative technologies to be introduced into our healthcare marketplace to really transform our healthcare delivery system. So I'm going to start with more of a sobering note, which is the fact that we're all aging. It's not a good way to start a morning, but let's recognize something here. In California, as you probably know, we are aging rapidly. It's not that we're getting older faster, but more of us are getting older, and there are fewer coming behind us. What we see is over the next course of the first half of this century, we expect about a tripling of our senior citizen population, which is pretty tremendous. We currently have about a 38 million residents in California. We expect about 50 or so million within the half century. We expect at least 11 or 12 million of those to be senior citizens, with an increasing number in the 85 plus category. Why is this important? If you look at what we spend for senior citizens relative to others, you'll notice that there's a significant increase in our per capita spending for anyone over the age of 65, and especially in the higher age categories. So clearly, as we age, as you would expect, there's an increase in our per capita costs associated with that increased demographic. There's a second underlying issues going on here with our aging population, and that is the prevalence of chronic disease. So as you can see from this, we have not only an increase in chronic disease, we see that there's approximately 20% of our senior citizens will have just one chronic disease, that's diabetes, and that the prevalence of this has actually increased over time. So we not only see the aging population, but we see an increased prevalence of chronic conditions. And this is also important because it is part of the driver behind our increased cost structures. So for example, about 60% of our healthcare expenditures in this state were for people with multiple chronic conditions, not just diabetes, but diabetes and heart failure or two or more chronic conditions. This is only about 19% of our population. So about 19% of our population is attributed or accounts for about 60% of our total healthcare costs, whether or not you're a senior citizen. So we have a very small fraction of our population representing a very large cost and accounting for a very large cost. Clearly, this has implications for how we manage disease among our population, both the seniors and those who are younger. This has clear implications for the kinds of technology and innovations that would allow for better patient self-management and some of the technologies and innovations that you may be working with. Every other country in the industrialized world is facing the same kinds of cost pressures. What we're seeing in the United States is clearly an increase that's associated with other things. The inability for us to manage our costs relative to other industrialized countries is increasing our budget pressures both at the state level, as you well know, and at the federal level. So clearly we need to not only control our costs overall, but we do need to spend some time and more effort in controlling what's the dominant factor, which is chronic disease. So there are three programs that I want to talk about today, which are of significance and import, which may really be able to help us manage these costs and manage our populations better. The first is high-tech. So how many of you are familiar with the high-tech program? None of you. Nobody has heard of high-tech. Okay. So high-tech is the Health IT for Economic and Clinical Health Act. It is a component of the stimulus program that was initiated a year and a half ago, February of 2009. And it is an incentive program for physicians and hospitals to use electronic health records. It is a significant multi-billion-dollar program over the course of the next 9 years, which is intended to transform our healthcare delivery system using health information technology. How many of you are familiar with health reform? Okay, that's better. By 2014, we expect as many, if not more than 6 million Californians who do not have insurance to have coverage through health reform. So that is a significant increase. About 15 to 20% of our population will have insurance where before they did not. Clearly, that has implications on our primary healthcare delivery system. And then there are administrative transaction changes. This on its own is pretty significant. We have the biggest change in our administrative transactions since the advent of HIPAA, the Health Information Portability and Accountability Act. The two things that are happening is, one, that we have HIPAA 5010 transactions coming into place, which is a precursor to ICD-10. And ICD-10 is a diagnosis coding scheme which is going to significantly upgrade from our current ICD-9 coding scheme. Any one of these initiatives by itself is a major task for our healthcare delivery system. All three of these are coming full force within the next 3 years. So we have major pressures happening on various components of our healthcare delivery system, which have implications for all of us, whether or not we're a patient or a provider or both. The reason why the federal government has chosen to focus one of its initiatives on health IT is because we lack and lag behind almost every industrialized country in the world, save Canada, on the use of electronic health records. So while some of these countries, for example, Netherlands, New Zealand, and Denmark, that's not pictured here, have had electronic health records in some cases for decades. Now, they have a very different healthcare delivery model. They're not, they may be a single payer. Germany, however, is not. The fact is that you have physicians who have been using for decades electronic health records, and they are able to do it in a way that improves healthcare quality. So it's not necessarily a technology issue we're dealing with in this country. In many respects, it's a cultural issue. So what is happening with high-tech? First of all, as I mentioned, the first of the 3 programs that are coming this way, the high-tech program expects to see between $9 billion and $29 billion worth of incentives to physicians and hospitals that become what they call meaningful users of electronic health records. So these are incentive payments on top of what they receive from Medicare and Medicaid in the state and Medi-Cal. $44,000 to $64,000 per physician. $2 million plus per hospital for hitting what's called meaningful use of an electronic health record. In the ambulatory EHR market, a report that just came out is forecasting that our ambulatory market is going to double within about a year and a half, largely because of this initiative. So we're going to see significant changes and ramp up in the EHR market just in the next 2 years, attributed mostly to this program. High-tech has a few other components as well that you should know about. The first is the EHR incentive program, as I mentioned. We expect of the up to $30 billion, about $3 billion to come to California providers and hospitals who become meaningful users. The second program is something called the extension centers. We currently have 3 in California that have been funded, received over $46 million in federal grants. These are the technical assistance providers. They're the boots on the ground. They're the geek squad for the primary care physicians who are trying to adopt electronic health records. So they're funded to provide technical assistance to about 10,000 physicians in California. And then you have health information exchange. This is an area that we're very involved in. We applied for a federal grant at the Health and Human Services Agency and received a little under $39 million award. And what we'll do with it is we intend to support an institution called Cali Connect to fund and expand health information exchange, work with colleagues like the California Telehealth Network, our providers, our hospitals, to start delivering information in a safe, secure way. There are also workforce grants, because the market is increasing as much as it is, and this is a really significant, huge expansion of electronic health records. We need a workforce to support it. So community colleges have received funding to have certificate programs, mint new resources and people to help with this adoption. We obviously have our California Telehealth Network, which is not actually part of stimulus, but received a $22 million federal grant to connect over 800 sites across California to a virtual private network. So we have now the biggest telehealth network in the country that has begun to go live. And then we have something called beacon communities, which is essentially demonstration programs. And we have one of 17 in the country based in San Diego. I'm not going to go through these, but these are meaningful use requirements. Hospitals and physicians need to meet all of these in order to qualify and get their first incentive checks for your electronic health records. And these are things like the ability to exchange clinical information with other providers. So if you're a primary care physician and you refer to a specialist, you have to be able to demonstrate that you can send that specialist an electronic document that's a summary of that patient's visit and their history. There are about 15 others that they have to meet. And then there are these other, what they call menu set items. Physicians have to choose and hospitals have to choose 5 of these. And they have to meet all of the 5 that they choose in order to meet their meaningful use requirements and get their incentives. So it's pretty comprehensive in terms of what the providers and hospitals have to do in order to get their incentives. The Office of the National Coordinator, that's ONC, they're the administrator of this program. They're telling all states that you have to focus the first year of your program on 3 things. Electronic prescribing, which is sending electronic prescriptions from the ordering provider to the pharmacy, so that we don't have handwritten prescriptions anymore. We're not dealing with faxes. These are actual electronic transmissions of information. Despite what you may think, fax does not count as electronic transmission in this case. Receipt of structured lab results. So you need to actually be able to have a structured lab result in your electronic health record. No scanned documents. It needs to be able to be mappable to some in an alphanumeric form so you can actually chart and do analysis on the data that you have in your record. And the third, as I mentioned, is the sharing of electronic patient visit summaries. So those are the 3 areas of health information exchange that states are supposed to focus on in the first year of the program. As I mentioned, Cali Connect is essentially the state's agent in the field to support information exchange. They are going to roll out the adoption of a couple of services, an entity registry and a service registry. I'll explain those in a moment. It will be defining policies to allow for safe, secure information exchange, what they call a trust framework. They'll be expanding existing capacity. HIE is Health Information Exchange. And they'll be supporting an open, inclusive, collaborative process. Their board meetings are public. Their work group meetings are public. So they are intended to be essentially an organization that is open to all individuals who have a stake. The 2 services that Cali Connect are going to support, the entity registry and the service registry, are intended to essentially be a certificate authority for legal entities that can engage in exchange. A hospital, a clinic, a practice, a health plan, a pharmacy, an immunization registry. These are the kinds of legal entities that can approach Cali Connect and say, I want to be connected to the network. And then Cali Connect can issue a certificate, a digital certificate that will allow it to exchange data with other trading partners in a safe, secure way. The service registry is essentially the web address for where all of these providers live. So it's a routing service and it's a certificate service that would allow, for essentially the health internet, so that we finally have a way to connect all of our institutions to each other. We've heard this repeatedly from our hospital partners, people like UC Davis Medical Center, like the Catholic Healthcare West and others, Kaiser, that they want this kind of network to connect themselves to. Many of them have the infrastructure in place in the hospitals, but they don't have the ability to transmit it to others in a safe, secure way. So that's what's being planned. So I want to talk a little bit about health reform, because this is the second of the 3 initiatives that I mentioned earlier that have huge implications for what we're doing on a day-to-day basis in healthcare. First of all, under health reform, by 2014, we expect 94% of the state's population to be covered by a health plan. And it'll be either through their through their employer, a new health insurance exchange program, or the expansion of public health programs like Medi-Cal. Medi-Cal is the state Medicaid agency. It has 7 million people currently enrolled, and it expects to see possibly 2 million more added to it by 2014. So it's a massive expansion of insurance programs, both in the public and in the private sector. We expect to see something called accountable care organizations. Have any of you heard of this term, ACOs? No. Okay, ACOs. Well, no one's defined it yet, so that might be why you haven't heard about it. But it's in statute, and these are intended to be organizations that assume some sort of global risk for patients. So it could be like an independent physician association. It could be a hospital. But they essentially are assuming some sort of global risk like a capitation payment and have to manage the entire cost of that patient's care. They would do it for a population, and they would have to demonstrate that they can manage their care under that payment scheme and demonstrate that that they are able to improve quality and reduce costs. So it's a huge task that would be associated with these demonstration pilots. You have insurance exchanges that are expected to be up in place by 2014. These insurance exchanges would be like e-health insurance, where you can actually go online, find out where you can buy insurance. You can actually compare and contrast your options in terms of your cost and your benefit. There'll be minimum benefit definitions, i.e. you have a minimum set of benefits that each insurance policy would have to support, and you would not be denied coverage for pre-existing conditions. In order to do that, these insurance exchanges have to risk adjust. So they have to be able to access something about your history in order to change what the insurer would be paid in order for you to sign up to them. But again, they would be unable to deny coverage for people with any pre-existing condition. And then there are going to be significant reporting requirements for quality. So this is all components of health reform that we're likely to see. As I mentioned, there are 8.4 million Californians that do not currently have insurance. This came out a couple weeks ago. It was published in the LA Times. That's up from 6.4 million just 3 years ago. That's huge. The fact that we've lost 2 million insured people in California just in 3 years through this recession. Nationally, there were 7.3 million children who were uninsured in 2008. 65% of them were eligible for some kind of insurance program and were not enrolled in it. So even though you have an option of enrolling, they were not in a program. They were not covered by insurance. 39% of these kids lived in 3 of the largest states in the country, California, Texas, and Florida. So we still have a huge population that could be insured that is not. California could become the first state in the country to actually have legislation around a state health insurance exchange if the governor signs a bill that was passed by our legislature. This would appear to be a good thing and a good step for us in California. And as you all know, last week, day 64 of our budget, we still do not have one, and the governor is working with our legislative colleagues to try to come up with a budget resolution. To date, we still, as you know, do not have one. Finally, healthcare and primary care, health reform and primary care. This just came out in Health Affairs. I think it was on Monday, actually. Only 42% of the 354 million annual visits for acute care were made to their primary care physician or your personal physician. So fewer than half of these acute care visits were actually happening with a primary care doctor. The majority of these were happening in other settings, and over a quarter were actually happening in the emergency department. And almost all the visits that were taking place at night and on weekends were at an ED, as you might expect. Specialists and other outpatient departments accounted for, again, just over a quarter, about 27%. What's interesting is that there are fewer than 5% of our physicians practicing in these emergency departments, and yet they're seeing 28% of these acute visits. So clearly, this, again, has significant implications for health reform. Many of these patients had insurance, about half of them. So even though they were covered, they're still going to the emergency departments for things like the flu. Basic primary care needs should be met somewhere else instead of a high-cost setting like the emergency departments. But we're going to have to restructure how and where these patients get care and give them options other than the emergency department. Broad adoption of EMR systems and connectivity are necessary but not sufficient steps towards real healthcare transformation. Adoption of EMR systems and valid comparative performance reporting would enable the development of value-based competition and quality improvement to drive transformation. The bottom line is, while we have electronic health record programs that are being proposed and being put into place, those alone are not enough to make the changes that are needed to transform our healthcare delivery system, to improve what we have today. We need the kind of analytics and comparative effectiveness research, and we need to apply those into our healthcare delivery system. We need tools like electronic health records to acquire that data electronically, and then we need analytic tools to be able to synthesize it and understand what best practices are. And it'll help us understand things like our use of MRI data, our use of MRIs, and whether or not this is the appropriate kind of utilization. When we compare ourselves to other countries, At a macro level, we have between 2 and 4 times more MRI usage. What we need to understand is this the right kind of utilization? Is this driving better healthcare quality, or is this improving cost? Or is it improving cost effectively in improving quality? Or is this too much? The same thing goes for coronary artery bypass surgery. Is this the right level of care? Is it appropriate for us to be using 2 or 3 times more coronary artery surgeries than most other industrialized countries? We need health outcomes data to be able to prove this or not. We also need it to understand what's happening within our own geography. So if you're familiar with Dartmouth Atlas, the Dartmouth Atlas shows you how you have massive variations in care that have very little to do with the prevalence of disease or with age or anything else other than things like where a physician was trained and their surroundings. If you look at the variation in care in 3 neighboring counties, these are age, sex adjusted, you find 2 to 3-fold variation in coronary artery bypass graft surgeries. And the question is why? These people aren't older. The genders are basically comparable, but we have massive variation. We expect some, but 2 or 3-fold variation in neighboring counties doesn't seem to make sense. There's something else going on here, and we need to understand what is the right level of care so that we can educate our providers and our patients about what kinds of care they should be receiving. As most of you probably know, we do have some studies that have shown us how we have massive variation in care within populations and across different conditions. What we see is in the massive variation, 3/4 of women are receiving guideline care for things like breast cancer screening. But we go all the way down to things like ulcers and alcohol dependence, and 11% of our population are getting guideline care. This is care that's come out in randomized controlled trials and studies that show us what patients should be getting. Now, we probably shouldn't be hitting 100% on all of these. There needs to be some variation because there are individuals who, for whatever reason, don't necessarily need the kinds some tests or screening. There's a real role for personalized and individualized medicine. But we could do significantly better than this. I mean, what we basically find is that overall patients get appropriate care about half the time. So if we want to have better care, we need to have better systems to be able to understand what the right care is, what the appropriate outcomes are, so that we can improve our quality. I want to just give you an example of what it could look like in a primary care physician's office, what they have to face on a day-to-day basis. If you think about a typical primary care physician panel, maybe about 2,200 patients. This is clearly not a boutique practice. This is a regular practice. They may have 130 diabetic patients, and they have 6 quality measures upon which to keep track of. They may have 300 patients with asthma. There are 2 quality measures associated with those. 125 with heart disease, another 2 measures, and 500 women who are eligible for 2 forms of cancer screening, cervical and mammography. Take it all together, that's about 2,630 different discrete data elements or measures they need to keep track of. And when you think about it, the human mind can retain about 7 digits, so clearly they need technical support tools. They need electronic health records, they need chronic disease management systems and registry capability to help them, to help prompt them and their staff, to help recall patients who might need care, to reach out to them when they may need a foot check because they have diabetes, or when they may need a mammography screen because they haven't had one in 2 years. So these are the kinds of issues we're dealing with, and we need tools and decision support tools to help physicians and clinicians provide guideline care. Our frustrations with machines are not going to be solved with better machines. Most of our technological difficulties come from the way we interact with our machines and with other people. The technology part of the problem is usually pretty simple. It's the people part that's complicated. As I showed you, there are countries that have had electronic health records for 20 years or more. We don't because of sort of the cultural issues that we just haven't gotten to the point of requiring, demanding, using it on a day-to-day basis. EMR tools can certainly get better, but we can use them today. We just need to help the clinicians who are providing our care to use the tools that are available to them. There are some form factors that are clearly going to be helping with this transformation. Things like iPads, which are becoming much more prevalent and which clinicians are starting to carry around more often, could become good platforms that will speed the adoption of electronic health records. I want to finish just with an example of one organization that has implemented an electronic health record, much like UC Davis Medical Center has, and some of the outcomes that they've seen from it, and what it means when patients are engaged in their healthcare decision-making. Health Connect is their electronic health record at Kaiser, and Hawaii was their first region to go live on Health Connect, and so they have the most data on it. They went live in 2007, and what they found is when they added this Health Connect patient portal, which allowed patients to ask physicians questions, schedule appointments, refill prescriptions, look up lab tests, they found that their age-sex-adjusted total office visit rate decreased by a quarter. Their scheduling telephone visits increased more than 8-fold, which means they had secure email messaging, which began in 2005, and it increased by 6-fold. The most visited feature on the website in 2007 was viewing lab test results. And by 2007, 62% of members registered on kp.org accessed the site 2 or more times in a 6-month period. So they're essentially using this as much as they're using online banking systems or other kinds of electronic retail marketing and transactions. In terms of what they do nationally now, about 21.5 million test results are viewed online, and this is just increasing as patients become more familiar with the tools. And 8.5 million visits, million emails to physicians, by its members. That was just in 1 year. A couple of weeks ago, a study came out on quality and the use of Health Connect. What they did is they looked at a population and they looked at email between patients with diabetes and hypertension, again, 2 chronic conditions, with the doctors, and they found that the interaction was correlated with an improvement in care quality. In this group, there were 35,000 patients with this diabetes and hypertension, or both. It was associated with statistically significant improvements in HEDIS. That's a quality measure score measurements, and the results included a 2 to 6.5 percentage point improvement in glycemic control, that's blood sugar, and blood pressure screening and control. So not only the frequency by which they were tested, but actual control. So there were actual physical improvements in the quality of patient care associated with this increased use of email and electronic notification of patients. Patients initiated 85% of the secure messaging. So this was really a patient empowerment tool. It allowed them the opportunity to ask the clinicians questions to better understand their condition, and it led to improvements in quality. The federal government is very much interested in seeing these kinds of tools put in the hands of patients. So the Veterans Administration, the VA, which has had an electronic health record for quite some time, is initiating a program called the Blue Button. The Blue Button gives the ability of vets to download their personal health information into a format that can be used in other settings. It could potentially be used through one of the personal health records, like Health Vault, or it could be delivered to an electronic health record for a provider that's not in the VA system. So they're releasing this, they're launching this, and they hope to see more veterans empowered by the access and control of their health information. You can find us on the web. We're very interested in having dialogues with all of our stakeholders. We have a listserv that you can sign up for, and we only send emails a couple times a month. We have monthly webinars which provide updates to the field of not just what we're doing, but what's happening in California and nationally. We have a website, obviously, with current information, and we use Twitter and Health 2.0 kinds of tools. With that, I think we have time for questions.
Yes, we do. Jeff.
Thanks very much for your presentation. My question
When you say is there a model, do you mean in other countries or I just want to make sure I understand your question.
my question was about
I think our evidence is and again, this isn't necessarily my area of expertise, but in terms of innovation in some forms of technology, the evidence in California and generally in the United States is fairly limited. It's limited somewhat to research findings. Right. Mm-hmm. I would imagine there is. I have not seen a sophisticated model, like a GLM model that has multiple equations where you can say if I input this particular technology, which might be home health monitoring, into the equation and I roll it out to 50,000 people with a chronic condition, it reduces my cost by X and might increase quality by Y. So I imagine that there are companies that have done this. I've seen companies like IBM that have very sophisticated models of economies and of healthcare delivery systems, which probably do have that level of sophistication. I have not seen that particular model. I would think that it would be incredibly worthwhile to have and to be able to use to test out some innovations to see whether or not we actually can predict what new technology and innovation can do to our healthcare delivery system costs and outcomes.
So it might be particularly useful if such a model were created by an independent agent, separate from the actual healthcare providers.
Yes.
That had some pretty good credibility in developing and moving forward these technologies.
I would think so. I mean, this may be a role for someone like CITRIS or for an academic medical center or an academic institution to.
That's a good idea.
To do. I know there are some plans and some funding for evidence-based medicine and some modeling. I don't know if it's to the level of sophistication that we're talking about, but through the stimulus program for some academic institutions to do some level of modeling. I don't think it's to create quite the model that you're proposing here, but I do think it would be of tremendous value. The challenge will be to get high enough quality data that would make the model relatively realistic, like everything.
Thanks again for your great presentation.
You bet. Thank you.
Other questions? Edmund.
Yeah, so I thought the Kaiser Health Connect was very interesting in that it seemed like there were very sort of concrete indicators or concrete measures of success or of things working right.
Yeah.
And I'm wondering whether or not there is a comprehensive template or a set of indicators that we might use as technology providers for gauging whether or not we're providing technologies that are A, being used, and B, providing good quality of care, and perhaps C, providing the cost savings that are so important.
I don't know that there is yet a template. What one of the things Kaiser focuses on is it focuses on standardized quality measures, and that's important in any kind of scientific research, right? You need to be able to have replicable quality measures, like in any science, that you can replicate in other settings. And so one of the things that I think is interesting about Kaiser is they took something called HEDIS, which is your basic quality measures, and they tested and looked at their population and compared it to others. I don't think there is necessarily a template. I think what you need to do is you need to start with a common set of measures that you're going to judge the outcome by. And one of the things that is interesting about Kaiser is you have a case control. You have a group that uses the technology versus those that don't. Aside from that, whether or not you can actually create, I think that's basically it. I don't know that there is I think that's basically it.
Other questions? Yes, up and left.
Just to follow up with the Kaiser results, because Kaiser population a little bit skewed because all their patients are insured, educated, most of them. Like for other, primary cares, a lot of Medicare, Medicaid patients, most of them are not educated. They may not be able to use that technology very well. It's just my comments.
Yes, absolutely. And so I think two comments. One is that this was all within the Kaiser system. So it was comparing Kaiser to Kaiser patients, those who used versus those who didn't. The second thing is I agree that there's limitations with the ability to communicate with those who English may not be primary language or who have different levels of education who are uninsured. My pushback is that I've seen in some settings those hurdles overcome. And one was in a clinic up in Columbia Basin, Washington State. This is 3 hours inland from Seattle. It was a rural community. It was a federally qualified health center. It was a clinic. About 2/3 of the population, 3/4 of the population was under 150% of federal poverty. More than half spoke a language other than English at home, where English was a second language or a third language. And they were using electronic health records and doing the same kind of quality measurement that Kaiser did, and were able to show that by not only using the record, but by having a very data-driven focused processes for population health, that they had depression screening, PHQ-9 screenings, they had diabetes foot checks and microalbumin testing that was within the 90th percentile of commercially managed HMO patients. So they were actually able to use a system for a very poor migrant farm worker population that mostly didn't speak English, and they're actually able to get results that were within the 90th percentile of commercially managed care patients in the country. So you can overcome these barriers. It's not easy, but with the right set of I think, with the right funding, although they're federally funded, so they're not a rich community, they're not a rich clinic, but with the right set of leadership skills and processes in place, you can overcome those challenges and become better than most commercially managed insurers and healthcare delivery systems.
Dr. Boyd?
I just have sort of two general comments on I always find it very interesting when people in healthcare put up graphs showing, for example, healthcare utilization. And coming from a different system, I came from Canada, so I've got an idea of how that system works. Two comments. The first thing is we talk about, for example, the use of MRIs. We look like, what are these doctors in the U.S. doing, ordering all these MRIs? The first time you have your butt in front of a judge because because you missed something, that changes the way you order tests. Now, the trial lawyers would have you would say, tort reform will not impact, it's only 1%. Well, first off, 70% of malpractice is all thrown out, and there's no payment.
Yep.
But the other thing is, I think we have to address, it's one thing to go by practice guidelines, but I truly believe that a lot of the built-in cost is ordering these tests just because the worry or the threat of litigation. That's one thing. The second thing is, when you look at MRIs and how could be ordering so many? I can tell you right now, when I go back to to Ottawa, where I came from, there were 3 MRI machines in the whole city. The waiting list is 6 months long. It goes 24/7. So until Americans are ready to eliminate immediate gratification and ready to accept limitation of access to resources, it's going to be very, very difficult to get those things in line. So that's just...
I agree. I grew up in Winnipeg, and so I'm also familiar with the healthcare delivery system up there. In Winnipeg, there's a Center for Health Policy Research, which actually Lesnor LaRousse ran it. There are a couple of really amazing individuals who had population health data on 1 million provincial residents in the province, and they were actually able to use policy to affect policy because they had such good data, and were able to say, we may need another MRI machine, or we may need to change our reimbursement system. One of the other things that was in the Health Affair article that I mentioned back here was spoke exactly to your point, which is that physicians are frequently practicing what they call defensive medicine, which is making sure they're ordering everything they possibly can to eliminate the threat, or to minimize the threat, can't eliminate it, of tort, of being sued. In a companion article that came out, they found that that the liability insurance and tort basically cost the system about $50 billion, I think, a year. So we clearly have to resolve some of those issues. The health reform, the Health Affairs article actually said that that was not the biggest problem that we have to face, but it is a problem. And you're absolutely right. My sister who lives in Montreal had to get an MRI. She actually paid $750 to get it within a week, as opposed to waiting 6 weeks, which is what she had to wait if she didn't have the $750, which she's a professor, so she kind of does. But the bottom line is, Americans are going to have to realize that if we are going to change that cost curve, which is bending out of control, there is going to have to be some rationalization of medicine, or rationing of medicine. What we also have to recognize is that General Motors went bankrupt, and they went bankrupt because they spent more money on health premiums than they did on steel. And we are not going to be able to compete in a global marketplace if this continues to be the trend. So we have to be very rational about how we allocate our costs. We have to have a very good understanding of why decisions are made, and we have to get over the issues of things like, if you are in urgent need of an MRI, you get bumped to the top of a list. So we have to be able to manage the resources that we have, and we're not doing that right now.
Opportunity, I think, for CITRIS is one of the ways of being more efficient. And I think that's one thing they've done very well in Canada is concentration of resources, of high-end resources.
Yep.
Now, if you look, you showed bypass surgery. Well, why is every little hospital everywhere doing bypass surgery? That doesn't make sense. I mean, to have the pumps and the perfusion, all the infrastructure required to get good outcomes.
Yep.
You know, it's more rational to concentrate those in bigger centers. And for these major procedures, neurosurgery, orthopedic surgery, and cardiac, to concentrate those resources. And that is one of the areas that I think that, you know, as a group, that we could definitely positively impact change by you know, concentrating the physical resources, but having outreaches, you know, through telemedicine.
Completely agree. And if CITRIS can do what the Center for Health Policy Research did in Winnipeg and in Manitoba, the ability to affect policy using good data will allow us to allocate our resources more effectively. So, absolutely agree.
Thank you all very much. Jonah, thank you so much.